We looked, ISAZA, this study is actually from ISAZA 2002, I think couldn't get the words here because it's different PowerPoint. The experience from oocyte donation showed that the oocyte and embryo quality was not affected by coasting. And this is quite reassuring because when they look at the recipients from the donors that were coasted and the recipients from donors who are not coasted, the fertilization rate was similar, the cleavage rate similar, and when they transferred an equal number of embryos on both arms, the implantation rate and pregnancy rates were similar. And this was further shown by Aslan that for the coasted group, if you had frozen all the embryos, the post-thaw survival, implantation rate and clinical pregnancy rate in the frozen cycle was similar to age-matched controls. However, coasting is not without its problems. It's not so easy to do. There are sudden drops in estradiol levels, unpredictable, or the levels could drop to very low levels, and then we have to cancel the cycle. Vaginal bleeding can also occur when there's a sudden drop in estradiol levels, so you cannot transfer back the embryos. If we initiated coasting at very high levels, as I will show later, the incidence of severe OHSS was shockingly or frighteningly high at 20% in some studies. And the frequent daily estradiol levels were not pleasant for patients and increased costs and workload for the center. In addition, there was no specific threshold level as to when to start or stop coasting, although later on we'll have a look at the review of all the literature. So because of this, Shawaf and Grosinskas decided to modify what others practice, which was a group that didn't need coasting and a group that need coasting. They decided to try it into 3 groups instead. They identified patients with very many follicles on day 6 or 7, and then for this group, they performed serum estradiol levels, so that you need to do serum estradiol levels on all patients. And if the estradiol level was less than 3,000 picomoles per liter, they considered this a safe group and continued on the same FSH dose. And in the bottom group, the high-risk group where the estradiol level was very high, and more than 25% of follicles were already pre-ovulatory at 15 mm above, they decided it was safe to coast. The problem is that there will always be an intermediate group where the levels are quite high, but yet most of the follicles are still quite small. If you do coasting, the fear was that prolonged coasting might cause all the follicles to undergo atresia and you get no eggs, or the estradiol level drops very much. So what they did was they did this study where they continued at half the original FSH dose. And when all 3 groups reached the common trigger criteria, which was when 3 follicles reached 18 mm and above, and the estradiol levels were less than 10,000 picomoles per liter. Note that this is picomoles now and not picograms. Different studies use different measurement. They triggered it with HCG 10,000, and the following are their results. It's quite reassuring that in the half FSH group, which is the top group, the implantation and clinical pregnancy rate was similar to the very high-risk group in which they coasted entirely till they reached the HCG trigger day. And the overall OHSS rate was 0.2% one patient, which is quite an acceptable rate, although, I mean, nowadays we prefer to have 0 severe OHSS. And in their modified coasting protocol, again, the fifth line, in number of eggs retrieved, there was a significant difference between the maintenance group, which has about 16 eggs retrieved, the half FSH group, which has about 14, and the coasted group at 11. But all this is moot point because the aim of ovarian hyperstimulation is get between 11 and 16 eggs anyway. So even if there's a difference, I think this was a good way to modify the coasting in order to ensure more patients, or rather there was a less cancellation rate and more patients could have an acceptable egg collection rate. In their outcome, the reduced group had similar pregnancy rate per cycle and per embryo transfer as the coasted group. And the reduced group did not have any severe OHSS because this was the fear that if you continue at half dosage, you might still end up with severe OHSS. Shawaf also reviewed a series of other studies at that time. As you can note that most of the studies were in the late 1990s and early 2000s, so that's about a decade ago. there was no consensus as to when they should start coasting. As you can see, it ranged from 9,000 to 22,000 picomoles per liter, and there wasn't a common consensus when to stop coasting either. Some stopped it at 9, some stopped it at 11,000, and there were some that didn't mention it or just mentioned a decline in the estradiol level. So overall, it's a very gray area where no one is quite sure when to start and when to stop coasting. And it seemed like more studies are definitely needed. So what's the best formula? If you're caught out in this kind of situation where you have a high-risk patient and you are on an agony cycle, whether short or long agony cycle, you might want to consider coasting if the serum estradiol levels are very high. Oops, hey. So we've gone. Okay, never mind. Just go forward and see. It's just suddenly. Follicles, as well as the size of the leading follicles, because as I said, if the follicles are all very, very small, then if you had to coast for more than a lengthy period of time, you might end up with no oocytes. And what type of cycle you are in. As I said, it's a moot point in terms of the antagonist cycle nowadays, because there are better options than coasting. So again, a look at all the literature that is out there. Majority, if you look at the third column, they started coasting when the estradiol levels are about 2,500 to 3,000 picograms per mole, and they stopped coasting at about the same levels. But none of these studies could agree on what was the follicle criteria or threshold when to start coasting. As you can see, they range from 5 follicles to 15 to 29 on the right column. So in general, if you needed to coast, I would suggest the following. Base it on your HCG criteria. Look at how many big follicles you have and how many small follicles you have, and give the HCG trigger only when the levels are less than 2,500 to 3,000 picogram per mil, or equivalent of 11,000 picomoles per liter. Is there a safe duration? As I said, there was disagreement among the authors, and although coasting more than 4 days resulted in non-significant decrease in number of oocytes, as I said, it's still very acceptable at 12 to 14 oocytes. Sorry. As you can see, 12 to 14 oocytes still acceptable. But when we looked at the implantation rate and pregnancy rates, many of the studies did show that there was a significant drop in implantation rate if you coasted for more than four or more days. And similarly, the pregnancy rate dropped when it's more than 4 days, and that's why the patient that's suitable for coasting, according to Gruzinskas and El-Shawaf, would be the one whose estradiol level is high, and yet at least 25% of the cycles were about 15 mm and above, because then you only need a coast for about 1 to 2 days, max of 3 days. Is it successful in reducing OHSS? A Cochrane review in 2011 showed that it did not seem to be of any benefit. However, that study, in that study, when they reviewed 16 smaller studies, the meta-analysis reviewed 16 studies, only 4 studies fulfilled the criteria for RCT trials. And a review of the literature showed that non-randomized trials and anecdotal anecdotes did show a reduction in severe OHSS rate. And again, I'd like to point out that 2 studies in particular had shockingly high severe OHSS rates despite coasting, this Egg-Base and Lee. And in these 2 studies, what was the outstanding feature was that Egg-Base started his coasting at very high levels, at 22,000, so it was too late. And Lee did not put a fixed criteria when to stop coasting. So as long as the estradiol level started declining, he gave the HCG trigger, and that might be one reason why these 2 studies had particularly high OHSS rates still. Overall, the coasting did not seem to affect the embryo quality and egg quality. ASH showed that this group of patients would be our nightmare patients. If you had very high estradiol levels, and if that was combined with more than 30 oocytes, you are almost certain to get a very sick patient. This, however, should not be a criteria to start coasting. This should just merely ring alarm bells that multiple strategies are needed in these patients, and perhaps even cancellation might be a safer choice. If you coast a cycle Was it certain you would get your eggs? No, definitely. And researchers have shown that if the estradiol level dropped by more than 20% per day, there was a poor oocyte retrieval, or if it dropped to very low levels, you probably won't get eggs. And when vaginal bleeding occurred, you probably won't get pregnancies. So in conclusion, this is a very small area if you have converted most of cycles to antagonists, but if you continue to use agonist cycles, coasting may be one of the tools you might use to reduce OHSS risk, but will not prevent it totally. We will still need to monitor the estradiol levels carefully as to when to initiate and terminate the coasting, and to still monitor for symptoms of severe OHSS, because it can still occur despite coasting. Continuous refinements, of course, to coasting strategies are still needed, but with the move of the rest of the world to antagonist cycles, I doubt that there will be much more research in this area, and potential high-risk patients should be offered antagonist cycles with agonist trigger, particularly if they have had a previous episode of ovarian hyperstimulation. With that, I'd like to end my lecture by inviting you to come and visit us. This is our Arts and Cultural Center at Esplanade. It's a funny shape, and if you've been to Singapore, you recognize it. It's half of a durian, which is the smelly king of fruits they call in Singapore. So you must come and try that, despite its horrid smell. Okay, we would like to invite everyone to Singapore for the Singapore International ONG Congress in August next year, and we hope you come and pay us a visit and see some of the newer sites there. Thank you very much.